Hello, my name is Dr. Richard Langley. I am a professor of dermatology at Dalhousie University in Halifax, Nova Scotia, Canada, and I am delighted to be here today to answer questions and meet with through the lens. Yes, so the SPROUT study, which is a study that looked at pediatric psoriasis using a Premolast, we have a paper poster just being released today, which looked at patients, in pediatric patients being treated with a Premolast, but we broke it down in disease on this duration. So we looked at it less than 2 years, 2 to 5 years, and longer. What we were looking for is that there has been some evidence that early treatment results in better patient outcomes. So that early treatment, for example, with a step-in study with secukinumab and with the GUIDE study, both showed that earlier treatment resulted in better efficacy and more durable efficacy. And the question is, with tissue-resident memory cells, are we impacting the disease? Are we modifying the disease? So with a Premolast, which is a drug that it's an oral drug, very safe, but not as effective as some of the biologics, we wondered, would this effect be there too? We found that there was difference in each age group, where the sooner you started in the disease, not necessarily the younger, but the sooner, within those first year or 2 years, the response rates were superior. And so the key message that we're making is that early treatment matters, that timing matters, and that if patients have significant disease, the sooner you start. We believe the data is now showing across multiple studies, and now this is for the first time in pediatrics, we have data that even in children who have had a shorter disease duration, starting earlier matters. My keynote speech was on early treatment, a window of opportunity, and I really made 3 points. I said that early treatment matters, and I think that we all know in life that being early matters. It's important to be early, show up, and work hard. That's what we tell our children. That's what we were told as children. It's important. So in psoriasis, it turns out to be important. One, because the sooner you treat, the greater chance you have of impacting the patient's quality of life and preventing cumulative life impairment. Over time, if patients have untreated disease, we know that there's higher rates of depression, suicide, impact on quality of life in terms of even your ability to work, productivity, and impacts many aspects of your life. So that's the first point. The second point is the early treatment can affect comorbidities, and data is coming in that we can affect the development of psoriatic arthritis. And there's also, we've done research and others are showing that there's an improved survival if you treat it. And then the third reason that I mentioned was that early treatment can result in a potential to modify the disease, and that early treatment may result in patients having better outcomes. So more patients getting clear and patients staying clear or having durability. The biggest unmet need now is that if you look at the treatment of patients with psoriasis, that even in the more severe, moderate to severe, that there is a huge number of these patients that are not receiving treatment. Whether or not it's because they're not getting access to trained dermatologists who can do it, or whether there's some resistance to prescribing treatments, this is one area. The second area is that patients with more what we call moderate disease, so probably not as extensive in body surface area, but still impacting critical areas, hand, feet, scalp, those patients are often undertreated as well. And so we need to have treatment. And within that group, hand-foot psoriasis is really emerging. There's some exciting data coming out showing that this is really a very heterogeneous disease and that the approach to it is unique. And we're working on a number of protocols right now trying to sort that out. So I think the unmet need is that we have great treatments, but the access is not there. I think that the next level is to recognize that the treatments are not 100% yet, and there's certain subtypes like palmoplantar disease and other types like pustular disease where we need to do better. And particularly if we look at atopic dermatitis, we need to do better. And I think the really exciting part now is what's happening with artificial intelligence and the ability to develop molecules and the ability to target not just one target, perhaps being bispecifics and trispecifics, and that there is going to be some exciting data, coming out. And much of this is coming also from China, that we're seeing in parallel what used to be the case, that many of the drugs were being developed in the US. We're seeing now this becoming more global. And I think the unmet need is that we have patients throughout the world, and we need to develop expertise throughout the world at developing molecules and working together as a global community to help all of our patients.